So in this deep dive, our mission is to kind of map out that landscape for you, pull out those crucial insights about MS, and really try to understand what it means for people, whose lives are actually touched by this.
Yeah.
And we want to do that without getting too bogged down in, the super technical medical jargon.
Absolutely.
So we're going to unpack what MS is at its core, who typically gets it, how it progresses in different ways, how it's diagnosed, some of the potential causes that people are looking at, and all the ways it can impact the body.
That's right.
So let's dive in.
Sounds good.
Where do we even begin? I mean, what actually is multiple sclerosis?
Yeah, that's the place to start.
Okay.
What is it?
So at its heart, what are we looking at here?
Well, we're looking at a condition that is, first and foremost, chronic, meaning it's long-lasting.
Okay.
It is immune-mediated, so that tells us right away that the body's own immune system is somehow involved.
Okay.
And it's inflammatory, and it targets the central nervous system.
The CNS.
The CNS.
Yeah.
And that includes the brain, the spinal cord, and the optic nerves. Think of the CNS as your body's main control center.
So it's almost like your own defenses are turning against this really critical part of your system.
Exactly. That's exactly it. And the key process that's happening here is something called demyelination.
Okay.
Now, to picture this, imagine the electrical wires in your home. They have that insulation around the right to make sure that the electricity flows smoothly.
Yeah.
So in your nervous system, your nerve fibers are like those wires, and myelin is that protective insulation. What happens in MS is that this myelin sheath gets damaged or destroyed.
And if that insulation is damaged, the signals can't travel as efficiently.
Right.
It's almost like a frayed wire.
Exactly, like a frayed wire. And that disruption in how nerve signals are transmitted is what leads to that huge range of symptoms that you see in MS.
That makes a lot of sense. So who is it that typically experiences this?
Right.
Is there a particular age or a demographic that's more commonly affected based on the stuff you've been looking at?
Yeah, so the typical age of onset when somebody starts to show symptoms of MS is between 20 and 40 years old.
Oh, wow.
Which, as you can imagine, that's a time in life when people are really active.
Yeah, absolutely.
Really starting to, hit their stride.
Right.
And what's really interesting is that there's a significant difference between men and women.
Okay.
Women are 2 to 3 times more likely to be diagnosed with MS than men are.
Wow, that's a pretty huge difference.
It is, yeah.
Is there anything in the material that you've looked at that offers any insights as to why that might be the case?
Yeah, there are a number of theories about this. Hormonal factors are suspected to play a role, as are genetic predispositions that might differ between men and women.
Oh, interesting.
It's a very active area of research.
Okay.
It's also worth noting that it's very rare to see MS in young children.
Oh.
Or in adults over the age of 50.
Okay.
So it really is that 20 to 40 age range that we see the most of it.
And you mentioned an increasing prevalence.
Right.
So has MS actually become more common, in recent years, based on what you've seen?
Yeah, the data does suggest that the number of people being diagnosed with MS has been increasing in recent decades.
Wow.
And this increase has been particularly noticeable among women.
Huh.
And this could be due to a number of things, including advancements in diagnostic technology. We're able to identify cases maybe earlier and more accurately now. And perhaps even changes in environmental factors that we're still trying to understand.
Okay.
There's a lot we don't know.
So now we have a picture of what MS is and who it tends to affect.
Right.
What about how it progresses?
Yeah.
Because I understand from the material that it's not the same for everyone.
No, it's not.
There are different ways that it can kind of unfold?
That's a really important point.
Okay.
There are several recognized clinical courses of MS.
Okay.
The most common one, when someone's first diagnosed, is called relapsing remitting MS.
Okay.
Or RRMS.
RRMS. Okay.
And this affects about 85% of individuals at the beginning.
So the vast majority of people.
Yeah.
Okay. Relapsing remitting.
Right.
So the name itself kind of suggests a pattern of ups and downs.
It does, yeah.
So for someone with RRMS, what might they experience?
Well, it's exactly as it sounds.
Yeah.
RRMS is characterized by these relapses.
Okay.
And those are basically like flare-ups or attacks where you might notice a worsening of your neurological function. So perhaps some new symptoms appear, or existing ones get more severe.
Okay.
And then these relapses are followed by periods of remission,
Okay.
where there's either partial or complete recovery of those functions.
So you might go back to your baseline, or at least close to it.
Exactly.
But then you don't know when the next relapse is going to come.
Right.
That sounds really challenging.
Yeah, it can be quite unpredictable.
And difficult to live with.
Yeah.
Okay.
Then there's primary progressive MS,
Okay.
or PPMS,
PPMS.
and this affects about 15% of individuals right from the start.
Okay.
So this is a different cause entirely.
So it's less common.
Much less common, yeah.
But it still affects a significant number of people.
Oh, absolutely.
Okay.
And in PPMS, you don't see those distinct relapses and remissions.
Okay.
Instead, there's a more gradual and continuous decline in neurological function right from the beginning.
So rather than those clear-cut attacks, it's more of a steady progression.
It is, yeah.
Right.
We also need to touch on something called clinically isolated syndrome,
Clinically isolated syndrome.
or CIS.
CIS. Okay.
And this is when you have a first episode of neurological symptoms.
Okay.
That lasts for at least 24 hours.
Okay.
And this can be the very first indication of MS. But it's important to understand that not everyone who has CIS will go on to develop MS.
Oh, okay.
It really depends on, what further investigations show.
So it's almost like a first warning sign.
Yeah, you could think of it that way.
Okay.
Then we have secondary progressive MS.
Secondary progressive, so that suggests that it comes after another stage.
Exactly.
Okay.
And this often develops in people who initially had relapsing remitting MS.
Oh.
And typically this transition happens some years after the onset of their RRMS, often around 10 to 15 years.
Okay.
And in secondary progressive MS, there's a gradual worsening of disability over time.
Okay.
You might still experience relapses, but the overall trend is towards that increasing disability.
So the relapses might become less frequent or less severe, but the underlying level of function is gradually declining.
Exactly.
Okay.
And finally, there's progressive relapsing MS,
Okay.
or PRMS.
PRMS. Okay.
This is less common.
Okay.
And it shares similarities with primary progressive MS in that there's this progressive decline in function from the beginning.
Right.
But with the added element of acute relapses or attacks happening along the way.
Okay.
So it's got kind of a combination of the two.
Okay. That's a really helpful overview of the different ways that MS can manifest and progress.
Right.
Let's go back to those attacks or relapses that are so characteristic of RMS and can also happen in PRMS.
Right.
What's actually happening in the body during one of those events?
Yeah. So during a relapse, there's this period of acute inflammation
Okay.
and further demyelination happening in the central nervous system.
Okay.
So it's like the immune system is becoming active again and launching another attack on the myelin.
And are there certain characteristics of these attacks that help doctors differentiate them from other issues?
Yes,
Yeah.
definitely. So first of all, to be considered a true relapse, those new or worsening symptoms have to last for at least 24 hours.
Oh, okay.
So it has to be more than just a passing thing.
Right.
It's also really crucial that these symptoms are happening in the absence of a fever or any underlying infection.
Okay.
This helps to distinguish a true MS relapse from just a temporary worsening of symptoms that might happen when you're sick.
Right. Like you wouldn't want to mistake, a flu bug for an MS flare-up.
Exactly.
Yeah.
Another important point about relapses in RRMS is that the onset of the symptoms is usually gradual,
Okay.
developing over a few hours or even a few days.
Okay.
And that's quite different from symptoms that appear suddenly
Right.
and are at their worst right away,
Mm-hmm.
which might suggest a different kind of event, like a stroke, for instance.
Right. So a slow, gradual buildup of these neurological symptoms
Yeah.
is a key indicator of a relapse.
Exactly.
Okay, so the material you've given us also highlights that these lesions, these areas of damage, can occur in various parts of the CNS,
Yeah,
leading to a whole array of clinical presentations.
it's true.
So can you walk us through some of those key areas and what kind of symptoms arise depending on, where these lesions are?
Of course, yeah. So because MS can affect different regions of the brain, the spinal cord, and the optic nerves, the symptoms can be very diverse.
Makes sense.
So let's start with the optic nerves, which connect your eyes to the brain.
Okay.
When a lesion develops here, it can lead to something called optic neuritis.
Optic neuritis.
And this is actually a very common first symptom that people with relapsing remitting MS experience.
Wow. Okay.
And, imagine you start to lose vision in one eye,
Yeah.
often accompanied by pain,
Yeah.
especially when you move your eye. You might also notice your ability to see colors vividly is reduced.
Oh, wow.
And this vision loss typically gets worse over about 2 minutes and then slowly recovers, although sometimes the recovery is not complete.
Okay.
And you might have some lasting visual changes.
So if a doctor was examining someone who's experiencing this optic neuritis, what would they see, like, during an eye exam?
So during an eye exam, what's called a fundoscopic exam, where the doctor looks at the back of your eye,
Right.
the optic disc, which is the part of the optic nerve that you can see, might actually appear normal.
Oh, interesting.
And that's called retrobulbar neuritis.
Retrobulbar neuritis. Okay.
Yeah, because the inflammation is actually behind the eyeball.
Okay.
In other cases, the disc might appear swollen during the acute phase.
Okay.
And then, after the attack, over time, it can become pale.
Okay.
So there are different things that you can see.
Okay, moving down from the optic nerves, let's talk about the spinal cord.
Right.
So if lesions happen there, what might that feel like, or what might the impact be?
Well, inflammation in the spinal cord is known as myelitis.
Myelitis.
And that can cause a range of sensory and motor symptoms in the limbs.
Okay.
And the onset is usually gradual,
Okay.
evolving over hours to days.
Okay.
And how severe it is can vary.
Okay.
So you might have, mild sensory changes like tingling or numbness, or you could have significant weakness in your arms or legs, even to the point of, all 4 limbs being affected.
And that would be what they call tetraparesis.
Exactly, tetraparesis.
Okay. And I remember seeing some specific signs that might point toward spinal cord involvement.
Yeah, there are a couple of kind of classic signs.
Okay.
So if there's a lesion in the cervical or neck region of the spinal cord, you might experience what's called Lermit's sign.
Lermit's sign, okay.
And that is, it's a sensation, it's like an electric shock that runs down your neck and back.
Wow.
And sometimes even into your arms and legs.
Wow.
When you bend your head forward.
I can only imagine how strange that would be to experience.
It can be very, very strange.
Yeah.
Another interesting symptom associated with lesions in the thoracic or mid-back, part of the spinal cord is often described as an MS hug.
An MS hug, okay.
And this feels like a tight band-like pressure or squeezing sensation around your chest or abdomen.
Oh, wow.
And it can be, in some cases, really intense and has even been mistaken for heart problems.
Wow.
Because of that constricting nature.
So again, it really highlights how varied the symptoms can be and how careful you need to be in diagnosis.
Absolutely.
So what might a physical exam reveal if someone has spinal cord involvement?
So on exam, a doctor might find changes in sensation.
Okay.
So reduced ability to feel light touch or vibrations, or to know the position of your joints without looking.
And that's called proprioception.
Proprioception.
Okay. Yeah.
There might also be a sensory level, meaning a clear point on your body below which sensation is altered.
Oh, wow. Okay, yeah.
In terms of motor function, you might show signs of what's called an upper motor neuron lesion, which can include increased muscle tone or spasticity, weakness that follows a certain pattern,
Okay.
exaggerated reflexes,
Okay.
and a specific finding when the bottom of your foot is stroked.
Okay.
In some cases of myelitis, you might even see a pattern of symptoms that suggests involvement of one side of the spinal cord more than the other.
Oh, wow.
What's called a partial Brown Sequard syndrome.
Okay. So really, again, just a wide range of effects.
It is, yeah.
What about lesions in the brainstem?
So the brainstem is a really crucial area.
Okay.
It controls lots of really fundamental functions, including some that are related to the cranial nerves.
Okay.
Lesions here can lead to things like double vision,
Okay.
a sensation that things around you are moving or bouncing,
Wow.
numbness or tingling on your face, vertigo,
Okay.
and difficulty with speaking clearly.
And that would be
Dysarthria.
dysarthria, okay. And I believe there's a particular finding in the brainstem that was mentioned as being, especially suggestive of MS.
Yeah, there is.
Okay.
It's called internuclear ophthalmoplegia,
Okay.
or INO.
INO. Okay.
And this refers to a specific pattern of difficulty with eye movements.
Okay.
And when it occurs in both eyes,
Okay.
it's called bilateral INO.
Bilateral INO.
That's very strongly suggestive of MS,
Okay.
often considered a hallmark sign.
So if that's present, it really points to MS.
It really does, yeah.
Okay. Good to know. What about the cerebellum?
So the cerebellum is really important for your coordination and balance.
Right.
So lesions here often manifest as something called ataxia,
Ataxia.
which is a lack of coordination leading to these kind of clumsy movements
Okay.
and problems with balance,
Okay.
making it hard to walk,
Okay.
hard to do other coordinated activities.
Okay, so pretty impactful. And then finally, lesions in the periventricular white matter of the brain. What might those cause?
So lesions in the area around the ventricles, which are the fluid-filled spaces in the brain,
Okay.
they can lead to cognitive issues,
Okay.
things like difficulty with memory and concentration,
Mm.
as well as changes in your visual fields.
Oh, wow.
It's also really important to remember that while MRI scans often highlight those white matter lesions,
Yeah.
there's also significant involvement of the cerebral gray matter in MS.
Okay.
And that gray matter involvement is increasingly recognized as a major contributor to symptoms like fatigue and cognitive decline,
Oh, interesting.
even though it might be less easily seen on a standard MRI.
Okay. So it sounds like MS can really affect almost any neurological function in the body, depending on where the lesions are.
It's true.
So given such a wide range of potential symptoms,
Right.
how is MS actually diagnosed?
Right.
Is there like one test that can definitively tell you?
Well, that's a great question. And the answer is no. There isn't one single test.
Oh,
It really relies on the overall clinical picture.
okay.
So that's the history of the symptoms that you've experienced and what's found during a neurological exam.
Okay.
The key is to demonstrate what we call dissemination in time
Okay.
and dissemination in space.
Dissemination in time and space.
Yeah.
Those sound pretty technical. Can you break those down?
Absolutely.
Okay.
So dissemination in space means showing evidence of lesions in at least 2 different typical regions of the central nervous system.
Okay.
And these regions include, the areas around the ventricles that we just mentioned,
Right.
the juxtacortical areas, which are near the outer layer of the brain,
Okay.
the infratentorial region in
Yeah.
the back of the brain, which contains the brainstem and cerebellum,
Okay.
and the spinal cord.
Okay.
So it's really about showing that it's not just one little spot
Right. Right.
that's affected.
Okay.
And then dissemination in time means showing that these demyelinating events have occurred at different points in time.
Okay.
And this can be shown by either having a history of distinct clinical attacks that happen at different times,
Okay.
or by findings on MRI scans showing that new lesions have appeared on a follow-up scan compared to an earlier one,
Okay.
or even by seeing on a single MRI scan, lesions that are at different stages.
Oh.
Some that are actively inflamed and others that are older.
So it's like putting together a timeline
Right.
and a map
Okay,
of the damage.
Exactly.
Okay. So what other kind of investigations play a role in helping diagnose MS?
So MRI is absolutely crucial for demonstrating both dissemination in space and dissemination in time.
Okay.
We look for those characteristic locations of the lesions.
Right.
Another important investigation is analysis of the cerebrospinal fluid,
Okay.
or CSF,
CSF. Okay.
which is obtained through a lumbar puncture, it's a spinal tap. And in MS, the presence of something called oligoclonal bands,
Oligoclonal.
or OCBs.
OCB.
Yeah, and the CSF indicates chronic inflammation
Okay.
in the central nervous system.
Okay.
And it can really strongly support the diagnosis, particularly in situations where the MRI findings are unclear, or in cases of primary progressive MS.
Okay. And I recall seeing something about evoked potentials being used in diagnosis.
So evoked potential tests, like visual evoked potentials, auditory evoked potentials, and somatosensory evoked potentials.
Okay.
They measure the electrical activity in the brain in response to specific sensory stimuli.
Okay.
So things like flashes of light, sounds, or electrical stimulation of nerves.
Okay.
And these tests can help to detect if there's a slowing down of nerve conduction along these pathways,
Okay.
which can be a sign of demyelination even if there aren't, obvious lesions visible on MRI.
Right. So it's giving you more information
Exactly.
to put the picture together.
Yeah.
Okay. And what about blood tests? Are those used to diagnose MS directly?
So blood tests aren't used to directly diagnose MS,
Okay.
but they are a really important part of the diagnostic process
Okay.
because they help to rule out other conditions that can sometimes mimic the symptoms of MS.
Okay.
So things like lupus, vitamin B12 deficiency,
Okay.
and other inflammatory or infectious diseases.
So it's kind of a process of elimination in a way.
It is, yeah.
Okay. So it sounds like getting to an MS diagnosis can be, somewhat involved.
Right.
You have to look at medical history, thorough examination, and then these
It's
investigations.
true.
So it's really about trying to put together all the pieces of the puzzle as accurately as possible.
It is, yeah.
Okay. So the trend seems to be towards trying to diagnose MS sooner rather than later.
Right.
Why is that so important?
It's become increasingly important
Mm.
because we now have a range of what are called disease-modifying treatments,
Okay.
or DMTs,
AMTs.
for MS, that can help to reduce how often relapses occur,
Okay.
lessen their severity, and hopefully slow down the overall progression of disability.
Okay.
And so the thinking is that starting these treatments earlier in the course of the disease may lead to better long-term outcomes.
Okay.
So that's why there's this push towards early diagnosis.
But I did also notice in the material a note of caution about the potential for misdiagnosis.
Yeah.
So can you explain that?
Of course. So while the push for early diagnosis is a good thing,
Yeah.
it's really important to balance that with the risk of incorrectly diagnosing other conditions as MS.
Okay.
This is particularly relevant when MRI scans happen to show white matter lesions in individuals who don't have a typical history of MS symptoms.
Okay.
Nonspecific white matter lesions can be found in various situations, even in healthy aging,
Right.
or in conditions like migraine headaches.
Okay.
So the McDonald criteria are specifically designed to be applied to individuals who have clinical symptoms suggestive of MS,
Mhm.
and shouldn't be used to diagnose MS solely based on incidental MRI findings in someone who feels completely well.
Okay. So the clinical picture has to fit with what's seen on imaging.
It really does.
Okay. So let's shift gears a little bit and talk about what might cause MS in the first place.
Let's do it.
Is there a single known cause?
I wish there were.
Yeah.
But the honest answer is that the precise cause of MS is still unknown,
Okay.
which is, as you can imagine, a source of frustration.
Yeah.
But the current understanding is that MS is what we call multifactorial,
Okay. Multifactorial.
meaning that it likely develops as a result of a combination of several different things interacting together.
Okay. So what are some of the key factors that people have identified as potentially playing a role?
So the most widely accepted theory is that MS is primarily an autoimmune disease.
Okay.
And that means that your body's own immune system mistakenly identifies components of your central nervous system, and particularly myelin, as foreign and harmful. And it launches this attack against it.
So it's like a case of mistaken identity, basically.
Exactly.
Okay. What other factors do we think are involved?
Well, genetic factors definitely seem to play a role.
Okay.
While MS isn't directly inherited
Okay.
in the way that some, single gene disorders are,
Right.
certain genes, particularly versions of genes in the HLA region, have been associated with a slightly increased risk of developing the disease.
Okay.
However, it's really important to remember that, having these genes doesn't mean you'll definitely get MS.